Good afternoon, dear friends. The subject of amnesia is important. The disorders causing problems of memory include vascular dementias and degenerative Alzheimer's dementias and head injuries, which are relatively common conditions. The less common situations include psychogenic dementias like dissociative amnesia and transient global amnesia. It's a serious problem. Lot of consequences and complications affecting employment, quality of life, dependence, education, learning, judgment, decisions, financial security, being lost and wandering, and being more prone to accidents. We, the neurologist, should suspect amnesia when the patient herself is complaining of problems with the memory, or when caregivers and friends are complaining of problems with memory. Sometimes we used to shrug off or neglect the subjective complaints of persons with memory problem, and we say that this may not be serious, forgetting is very common, but prospective studies have shown that persons with subjective feeling of memory loss in long term do have problems. We should also suspect amnesia when on the basis of history and physical examination and laboratory reports, for example, hypothyroidism or low B12 levels, there is a reason to suspect that higher mental functions could have been affected even though such complaints are not being made. We should suspect amnesia in children who are not learning well and when one or more risk factors for amnesia are present. There are a large number of complaints which are expected from a person with amnesia, and if one or more of these complaints are not forthcoming from the patient and caregiver, then we must ask leading questions. It's a long list. I will not read it thoroughly, and sometimes the hints can come indirectly by the family member and friends, and the severity of amnesia assessment is also important because they can interfere with the activities of daily life. Some people are unaware. We call it anosognosia of amnesia. On questioning, they may even deny the existence of a problem with the memory. Even caregivers may assert, "Oh, the memory is normal. Look, he remembers the events and people from 30 to 40 years back." The truth is that recent and short-term memories are more vulnerable and not the remote one. How should a clinician evaluate the memory in office or at the bedside? I would recommend that you must carry a text version of this section in Hindi or some other validated tool, maybe on a smartphone or a tablet, for the assessment. In the beginning, tell the patient and relatives that you are going to ask a few simple questions and apologize that some of these tests may seem childish and offending. We begin with telling a phone number, 7-digit, 8-digit, and we ask him to repeat after us. A normal person should have a digit span of 7, and we call it forward digit span. It is a test of immediate memory. Then we give another number and we ask the person to repeat it inversely, and we can give a word, say with 5 letters, and we ask him to repeat the alphabet or the letters of that word in a reverse order. This is also an example of immediate memory, and it is called backward digit span, and healthy people may repeat in a backward manner up to 4 digits. Then we give him some command, multi-step command, and say, whatever I am telling you, you do it. And if he is doing it properly, it's a test of working memory. He has to hold those commands in a working memory for a short while. He is not obliged to remember them. Then we ask him to repeat 3 or 4 or 5 unrelated words. It can be name of a city, a name of a flower, or a sweet, or a numerical number. And then we say, repeat after me. So when he is able to repeat after you, we call it registration or memorization. And then we divert his attention to something else for a couple of minutes. For example, 100 minus 7, and we say keep on subtracting 7 from the consecutive answers. This is a test again of working memory, but it is also a test of attention span. And then we test the recent memory. And for recent memory, we ask questions like, what did you have in the breakfast today? Which people have you met today? What has been the headline? What was the story in your favorite serial? If that story ever progresses forward. So these type of the things are assessment of recent memory. And now you come back to ask him, oh, please tell me those 3 or 4 or 5 words which you remembered. This is called recall. That was registration, and this is called recall. Then we come to remote memory. And in remote memory, we ask some questions like, where did you study when you were in 6th class? What was the address at that time? Who was the landowner? Who was the class teacher? Something like that. And you will have to verify them with somebody else in the family. Following questions are not the test of remote memory. Don't ask the date of birth or marriage anniversary or Prime Minister of India. These are not the tests of memory, particularly the remote memory. So all these things are part of general awareness. They are part of semantic memory, general knowledge. So we further divide remote memory into episodic and semantic. The first question, these questions are part of episodic. Episodic also means autobiographical, the person's own life, while the other questions of general knowledge are part of semantic memory. So these are two types of remote memories. We can also divide memory into short term and long term. In the short term, there are immediate recall, there is working memory, memorization and recall. While in the long term memory, we have episodic long-term memory and semantic long-term memory and procedural memory. What is procedural memory? We ask the person how to play a tabla, or how to make a cover drive, or how to do something, a skill in which that person has been trained. And this is a test of procedural memory. Memories are also specific to the sensory modality through which they have entered the brain. Some people are strong in visual, some other are strong in auditory, and so on. So those all were ad hoc, non-standardized, non-validated bedside assessment of the battery. But then to do a more formal assessment, there are test batteries which are used for screening purpose and for detailed purpose. Mini mental status examination Hindi versions are available online, and you should download them and carry them on a smartphone and use them very frequently. Or you can train one of the clinical assistants in your department to administer the MMSE, and there are many more. Like we have in India the Nimhans battery and the AIMS Delhi battery. The amnesia are divided into subtypes. We have physiological amnesias, which can occur in healthy people, and they are quite normal. Then there is mild cognitive impairment. It is defined as a measurable decline in cognitive functions which is not severe enough to interfere with the activities of daily life and job and leisure, and but it is not normal also. So this is mild cognitive impairment, and there is an amnestic variant. So there is a noticeable decline in the cognitive function, and they could be the precursor of Alzheimer's dementia and other dementias. Then there is semantic amnesia or semantic dementia, in which the knowledge about the world is affected not only at the level of naming but even at the level of concept, facts and beliefs. So a person may not be able to say this is a mobile phone, but he may forget what it is, why is it used, and so on. The person is at a loss to understand and interact with the world around her. This is called semantic amnesia. Episodic amnesia, as I said, is autobiographical memory. The information related to the facts and events from the one's own life is degraded, but the semantic part, The general knowledge part about the world, which is shared by all, is preserved. Recent episodes which have occurred over the last few hours to days, they are more vulnerable to as compared to remote events. A clinical assessment of episodic memory will need someone close in the family to verify the answers and provide opinion and facts. So, how the memory is stored in the brain? The short-term memory, the transient memory, the working memory is stored in related sensory areas, and it is very ephemeral or temporary. In the language of computer, we can call it as RAM, random access memory, which is not saved on the hard disk. These short-term memories or working memories are in the form of reverberating electrical potentials in the circuits. They have not been written. To write them, they have to pass through the hippocampus. So we can call hippocampus as the CD writer. That CD writer does not store the memories itself, but it sends them to various parts of the brain for storage. The long-term memories are spread out in different parts of the brain at the level of microscopic level, neurons and their synapses, and even at a gross level. So if a particular type of memory is enhanced, even the volume of that gyrus and the density of gray matter in that part of the cortex can change at a structural level. So when we say micro and macro, there are changes in long-term memory, and this is because of permanent changes in the synapses, the density of synapses, the density of networks, and the concentrations of various chemical neurotransmitters. All of them underpin the long-term permanent memories. And this is carried by a phenomena called long-term potentiation. So when same and same stimuli are coming again and again, Eric Kandel, the Nobel Prize winner, who did his ingenious experiments on a simple animal, a mollusk, squid, घोंगा, and the घोंगा or squid has two reflexes. One, he tends to खोल अपने खोल में चला जाता है as a defense, or he liberates ink in the water, dark color ink as a part of defense. So Eric Kandel studied the behavior of this animal on these two responses in response to many types of stimuli, and documented the phenomena in the very primitive, very simple nervous system, the phenomena of long-term potentiation. Post-concussion amnesia occurs in sports, and it can last for few days, few hours to few days, and the neurologist is called to make a decision whether those sports person can be permitted to participate in the ongoing event and in the future matches. Psychogenic amnesia can be very interesting and can be very peculiar. There is a sudden and total loss of autobiographical memory from the whole of the past life of a person, and then we call it global psychogenic amnesia. This happens only in movies and TV serials. Complete loss of personal identity and aimless wandering for a few days to few weeks occurs in a condition called psychogenic fugue. In such conditions, the memory loss is patchy and more persistent than in focal retrograde amnesia. Another variety of patchy loss is situation-specific amnesia, wherein there are gaps in memory for a particular traumatic event, and this occurs in post-traumatic stress disorders or PTSD. The differences between psychogenic and neurological organic amnesias have been summarized in this table. The predisposing factors for psychogenic amnesia are depression, stress, past history of similar neurological problems, while the neurological amnesias are because of those conditions which I enumerated earlier. The retrograde autobiographical memory loss is having a reverse gradient. That means more remote facts are more severely affected, while in neurological cases the gradient is that more recent events are not remembered while remote ones are preserved. The loss of personal identity is seen in psychogenic but not in neurological. Failure to recognize close relatives is common in psychogenic, rare in neurological, and anterograde memory. That means after the event, whatever is happening, whether that is retained or not, it is retained sometimes in psychogenic cases but can be severely affected in neurological amnesia. The transient global amnesia occurs at variable intervals of a few months to years. The imaging and EEG are usually normal. Vascular risk factors and a history of migraine may be present. Some patients may be referred to a psychiatrist by mistake. The pathophysiology is not known. We think it could be a TIA, it could be migraine with spreading depression, or it could be one of the non-convulsive seizures. The long-term prognosis is usually good. We may give anticonvulsants and antiplatelets and migraine prophylaxis, but we do not know whether they make a big difference in the long-term outcome. And finally, a few words about forgetting. Forgetting is common. Forgetting is essential. Everybody forgets and everybody thinks that nowadays they are forgetting more as compared to earlier years. The temporary reasons for forgetting are stress, fatigue and tension, multitasking, lack of sleep, intoxication, lot of noise, not taking meals correct time, hypoglycemia, having some fever, or some of the medicines like benzodiazepines and drugs with anticholinergic properties, they can affect the memory. Depression is one of the commonest causes of the complaint of forgetting. Depression is accompanied by lack of concentration, hence there is a failure to register. If something is not registered, it will not be recalled properly. It also depends, the forgetting also depends on your own interest, on your own strength. Some people are strong with faces, or geographical places, or words, or music. So there are a lot of personal variations. The forgetting can be retrograde and anterograde, particularly in acute events like encephalitis or seizure or head injury. And forgetting is certainly the hallmark, the sign now of dementias like Alzheimer's and frontotemporal and Lewy body dementia. Of course, it occurs in old age also. Some elderly people are affected more, some are less. Then people ask, how can we increase our memory? And the answer is experience, practice, and multisensory experience. So, use it or lose it. Then there is a concept of cognitive reserve, your bank balance. So those who have a higher bank balance, they will retain still more memory. But जैसे कहते हैं ना कि हाथी दुबला हो जाए तो भी हाथी ही रहता है. Good nutrition is important. Hygiene is important to prevent the infections. Exercise, there has been good evidence in randomized control trials about the beneficial effect of exercise. Reading and writing is crucial because whatever you write, you commit it to your memory in a more strong manner. To keep on working, and particularly physical work, is important. Socialization helps in networking, and it gives a rich multi-sensory environment which is necessary for good memory, good company. You should use many methods for stress busting, including meditation, good sleep, regular habits, and brain teasers. There is no role for tonics and vitamins and dry fruits and almonds and ghee and fish and magnet therapy and acupuncture therapy and herbal therapies. There are no effects. Vascular risk factors and complications have to be controlled. Hypertension, diabetes mellitus, coronary artery disease, high lipids, smoking, alcoholism, all of them interfere with the memory. We ultimately will need randomized control trials to claim whether a particular drug is working or not. This is very difficult to prove. So far, there has been no panacea, there has been no breakthrough, and we should not go for the media for the enhancement of the memory. And one of the recent Cochrane reviews said that all the cognitive intervention programs, they were not very effective. There can be modest improvement in the performance, and immediate and delayed verbal recall can improve, and these improvements did not exceed the improvement in active control conditions. So really on randomization there was no big difference. So with that I conclude. Thanks for your kind attention.